Vanakkam. Fortunately, we see a less number of active leprosy cases these days, but we still get to see patients with deformities of the hands following leprosy. And we plan the management for such conditions also to get back function in these hands. Why does leprosy affect some nerves preferentially? And what are the different ways in which the nerves are affected by the disease called leprosy? And if seen early, can the deformities following leprosy be prevented? For instance, can claw hand be prevented? All this and more will be discussed in this video on leprosy and the hand. The problem of leprosy still exists. In 2022, 182 countries registered new cases of leprosy according to the Global Health Observatory of the World Health Organization. There was a prevalence of 174,000 new cases, of which 39% were among females. And globally, more than 9,500 new cases were detected, and 3% of them were children. Among leprosy affected patients, the hands can be very seriously affected. There could be deformities of the hand because of loss of sensibility and consequent absence of pain. There could be disabilities of the hand because of motor paralysis. And both of these can be avoided by early recognition and management. So we need to know more about how leprosy affects the hand and the upper limb. We shall first see a small introduction followed by understanding the pathogenesis of involvement of the nerves in leprosy in the hand. We shall then see the clinical features and finally the management. The involvement of peripheral nerves in disease was first recorded by Danielson and Beck in 1848. In 1873, Hansen discovered the infectious agent that causes leprosy, the Mycobacterium leprae. It was in 1882 that Virchow recognized that peripheral nerve might be the primary seat of infection in leprosy. Let us try to understand how leprosy affects the nerve. The peripheral nerve is quite resistant to any infection, but Mycobacterium leprae is the only bacterium that can infect the peripheral nerves. This is because the Mycobacterium leprae affects only the Schwann cells of the myelinated and unmyelinated axons. The Bacillus Mycobacterium leprae exhibits a strong tropism or attraction for Schwann cells. This process has been studied in the 9-banded armadillo, which is a natural host for Mycobacterium leprae, just like human beings. The Mycobacterium leprae causes abnormal Schwann cell proliferation, and in the beginning it causes increased axonal regeneration. As Schwann cell proliferation persists, it leads to reduction in the regeneration of the axons. Finally, axonal degeneration and axonal edema results in axon loss. It is important to note that Mycobacterium leprae prefer the cooler areas of the body where they can multiply very easily. This will explain why the ulnar nerve, which is almost subcutaneous at the level of the elbow, and the median nerve, which is quite superficial at the level of the volar aspect of the wrist, are commonly affected. There are two hypotheses about how the bacilli gain entry into the Schwann cell. One is the cutaneous nerve retrograde spread, and the second is the vascular theory, in which the access is through the endoneurial vessels, where the bacilli penetrate between the endothelial cells and then enter the axon. The inflammatory process that results causes an increase in nerve thickness size. When there is involvement of a single nerve in the upper limb, it is usually the ulnar nerve that thickens. This represents 60% of those cases with just one nerve affected. When two nerves are involved, it is usually the ulnar nerve at the elbow and median nerve at the wrist. At the histopathological level, the hallmark of tuberculoid leprosy is the presence of epithelioid cell granuloma, a transverse section of the radial cutaneous nerve in a patient of borderline tuberculoid leprosy, showing a large focus of caseation necrosis in one fascicle, dense granulomatous inflammatory infiltrate replacing the endoneurial structures in another fascicle, and an unaffected fascicle C. On the other hand, in lepromatous leprosy, uninhibited multiplication of bacteria occurs predominantly in the Schwann cells. The histological features in this category are predominance of macrophage infiltrates, a good number of plasma cells, and scanty dispersed lymphocytes. Now let us see the clinical features of leprosy, especially in regard to the upper limb. The infection of leprosy could occur at two age peaks. The first is between 10 and 14 years of age, and the second is between 35 and 44 years of age. The commonest mode of transmission of infection is by airborne droplets from affected individuals when they sneeze or cough. The incubation period for this disease is quite long, almost 5 years. Basically, the diagnosis of leprosy is made on the signs and symptoms in which one of the following cardinal signs is seen in a region where leprosy is common. The first is a skin lesion consistent with leprosy. The second is definite sensory loss with or without thickened nerves. And the third is positive skin smear. According to Ridley and Jopling, there are 5 clinical subtypes of leprosy or Hansen's disease as it is sometimes known. Tuberculoid TT, borderline tuberculoid BT, borderline BB, borderline lepromatous BL, and lepromatous which is LL. Of these, tuberculoid and lepromatous are two ends of the spectrum which we need to understand. The tuberculoid form is characterized by a small number of hypopigmented anesthetic skin lesions, usually less than 5 in number, whereas the lepromatous form is characterized by numerous infiltrated skin lesions more than 5 in number. These skin lesions are well circumscribed and distributed asymmetrically in the tuberculoid form, whereas in the lepromatous form, they are distributed symmetrically and typically affect forehead, cheek, and earlobes. The tuberculoid form of leprosy is represented by a low bacillary load, otherwise known as paucibacillary or PB, whereas the lepromatous form is represented by a high bacillary load or multibacillary MB. A single nerve enlargement is characteristic of the tuberculoid form, and this enlargement is marked and brings about early damage, whereas in the lepromatous form there is very slow but progressive damage to many nerves. The nerve typically affected in the tuberculoid form could be the greater auricular nerve, the ulnar nerve, the superficial radial nerve, the common peroneal or the posterior tibial nerves, whereas in the lepromatous form, hypoesthesia of the extensor aspects of the leg, feet, forearms, hands, and more importantly, the involvement of the intrinsics of the hand and feet are affected first. The loss of sensation following affectation of the nerve in leprosy is mainly of temperature and pain, which are decreased early, and vibration and position sense are frequently normal. Nerve thickening is present in a high percentage of patients. These features are present in other conditions and should be differentiated. They can be present in diabetic and amyloid neuropathy also, but we need to remember that the deep tendon reflexes are usually preserved in leprosy, whereas not in these above mentioned conditions. Even in compression or entrapment syndromes of the nerves, the features may be similar, but biopsy of an involved superficial sensory nerve will point to the diagnosis of leprosy. Patients with all forms of leprosy, but particularly those with a borderline tuberculoid form, may develop abscesses of the nerves, most commonly the ulnar nerve. The diagnosis can be made with a high frequency ultrasound examination, which will show the thickening of the nerve and nerve abscess, if any. Confirmation of the diagnosis of leprosy can be made by many techniques. The first is a skin slit smear, where a small slit is made using a sharp blade over the skin of the earlobe, forehead, or lesional skin, and then a smear is made by scraping the exposed dermis onto a glass slide and examining for acid-fast bacilli under microscopy. But this is useful mainly for multibacillary leprosy. The lepromin test is an intradermal test for delayed type hypersensitivity to Mycobacterium leprae antigens. Although not specific, it is helpful for classifying the type of leprosy. Skin biopsy may show typical features depending on the type of leprosy. Mycobacterium leprae DNA polymerase chain reaction is a very specific test for detecting leprosy organisms. This picture shows a skin smear positive for acid-fast bacilli. If we get negative smears at all sites, it is called paucibacillary leprosy. But if we get positive smears at any site, it is called multibacillary leprosy or MB. The mainstay of treatment of leprosy is medical treatment by the multi-drug therapy. Here, a combination of drugs is used, and this combination depends on the classification of the clinical condition and the type of leprosy, whether multibacillary or paucibacillary. Rifampicin is the drug that is used in both types. For multibacillary leprosy, the combination of rifampicin, clofazimine and dapsone is used, and for paucibacillary leprosy, the combination of rifampicin and dapsone is used. The surgical management of leprosy in the hand is also important. It consists basically of three categories or types of surgery. The first type of surgery is surgery of decompression of the nerve trunk for preventing permanent paralysis. The second type of surgery involves surgery for acute infections of the hand and upper limb. The third and important category of surgery is the surgery for correcting paralytic deformities and disabilities resulting from muscle paralysis, usually tendon transfers. To describe a few of the surgical procedures, I have used the pictures from this document called Essential Surgery in Leprosy, Techniques for District Hospitals, written by H. Srinivasan and D. D. Palande, both of whom are international hand pioneers. Nerve decompression procedures can be external decompression or internal decompression. Relieving compression of the nerve trunk by structures external to it is called external nerve decompression. Example, carpal tunnel release for median nerve compression or epicondylectomy for releasing ulnar nerve compression. For external decompression of the ulnar nerve, medial epicondylectomy is done. First, incision is made over the region of the medial epicondyle. The medial epicondyle is then stripped of muscular attachments. Resection of the medial epicondyle is completed, and then raw area in the bone is covered by suturing back the soft tissues. Internal decompression is a procedure where decompression is done with epineurotomy, that is, the nerve bundles or fascicles are released from compression by the epineurium, which has become thickened, fibrosed or scarred. For internal decompression of the ulnar nerve, skin incision is made in the region of the medial epicondyle. Exposure of the ulnar nerve above the cubital tunnel is done, and then external decompression is done first by releasing the cubital tunnel. Incision for the epineurotomy is done as shown in the interrupted lines in the diagram. Marking of the incision used for internal decompression of the median nerve is shown. The indications for decompression of the ulnar nerve are when there are signs of ulnar nerve damage or increase in signs or symptoms while under treatment for leprosy. Appearance of pain on passive elbow flexion is also an indication for decompression of the nerve, and continued restriction of full active elbow flexion is also an indication. Surgery may also be indicated when acute infections develop in the hand or upper limb in a patient with leprosy. They could be infections in the fingers, palmar space infections, synovial sheath infections, or even a nerve abscess. Infections in the fingers could be in the form of paronychia, apical abscess, or pulp space infection, otherwise known as Whitlow or Felon. The incision for draining a unilateral paronychia is shown, where a skin flap is raised and excision of part of the root of nail shown by interrupted lines. A similar but slightly different incision is made for bilateral paronychia, and elevating this nail fold flap drains the collection and also allows excision of a portion of the skin and nail. Once this is done, a small dressing is applied between the raised skin flap and the nail bed. Apical infection is usually caused by a splinter entering under the nail and involving the nail bed. Treatment consists of not only removing the splinter but also excising a small wedge of the nail bed in that area which is infected. Pulp space infection, Whitlow or Felon, is drained by a lateral pulp incision. Palmar space infections in leprosy can involve the mid-palmar space infection or the thenar space infection. The incision for draining the thenar space infection is the incision along the thenar crease, and we may need another incision on the thumb web to access the thenar space. The incision for draining the mid-palmar space infection is usually along the distal palmar crease. Synovial sheath infections can involve the radial bursa or the ulnar bursa and proximally the space of perona. The incisions for draining these synovial sheath infections are shown in the palm and in the distal forearm. Nerve abscesses are of two types. The acute abscess is clinically indistinguishable from acute neuritis. It is not significant from the surgical standpoint. Chronic abscess refers to the cold abscess, as in tuberculosis, resulting from caseation and liquefaction of the affected nerve fascicles. These are usually not very painful and commonly seen in the tuberculoid type of leprosy. The nerve abscess may be wholly intraneural with nodular swelling of the affected segment of the nerve, here represented in blue color. It is covered by the nerve sheath. The abscess may break out of the nerve to form a collar stud abscess around the nerve. Drainage or decompression of the nerve abscess is required when there is partial paralysis of the nerve, complete paralysis of recent onset less than 8 weeks, or if the abscess becomes adherent to the skin and threatens to form sinuses. The procedure of decompressing a nerve abscess consists of an appropriate skin incision, 5 to 7 mm longitudinal incision over a nodular swelling if it is present on the nerve, and if there is no such nodular swelling, an incision needs to be made on the anti-mesoneurial surface, that is, superficial surface of the nerve. The incision is then deepened, and when the abscess cavity is struck, dirty yellow liquefied matter with flakes of chalky caseous material is removed. We also need to remove any obviously necrotic tissue, and we should stop with that and do no further dissection within the nerve. This is followed with a skin closure. Whenever any surgery is done on the nerve in a patient with leprosy, we need to follow a few basic principles. Since the nerve has already been affected, it is important to carry out meticulous dissection and take care of the nerve. Fine instruments must be used for any surgery on the nerve, and we need to avoid mopping the nerve surface with gauze pieces and instead use a saline irrigation for the same. It is important to preserve the epineurium and the blood supply of the nerve. We must also take measures to prevent post-operative scarring around the nerve, and this can be achieved by perfect hemostasis while doing the surgical procedure. The final category of surgery in the leprosy hand is the surgery for correcting paralytic deformities, otherwise known as leprosy reconstructive surgery. This is a wide topic, and a few of these topics, for instance, the correction of the claw hand, has already been discussed in a previous video. This video can be accessed by clicking on the link above. These tendon transfer procedures should be done only when the patient has shown good clinical response to multi-drug therapy, has had no reaction on neuritis within the previous 6 months, has no tenderness of the nerve trunks, and has had the deformity for at least 1 year. So in this video we have seen how leprosy affects the hand by involving the peripheral nerves, and also we have seen the clinical features of leprosy. And in the treatment options we have seen the procedures of nerve decompression, acute infection surgery, and timing for tendon transfers. I hope you enjoyed the video. Please do click on the shown links to see more about other surgical procedures in hand surgery. And do not forget to subscribe to stay connected with the latest in learning hand surgery, plastic surgery, trauma surgery and ethics. Vanakkam.